Thank you, Dr. Purvi, for giving me this opportunity to speak on this subject. My topic is tracking the blade my way. Uh, as we know, trabeculectomy is the gold standard, and which has been practicing. We have been practicing this for so many years. Long-term surgical success of TRAP depends on persistent lowering of the IOP without using further glaucoma medications, stabilization of visual acuity and visual field in addition to IOP reduction. This is dependent on formation of filtration bleb at the sclerotomy site and subconjunctival scarring. Prevention starts intraoperatively, as we already discussed. At the time of surgery, has to done very carefully. You have to master your surgical technique and including the perioperative medications. It continues postoperatively also, and there is necessary to promptly recognize the failing bleb to maximize the likelihood of its rescue. And a failing bleb requires careful evaluation to determine its predominant cause. So first 2 weeks there can be hyperemia, excessive vascularity. First 2 months there can be increase in the intraocular pressures, small bleb can be seen, and next is the encapsulated bleb, a small cystic bleb or a flat bleb. So these are the bleb patterns which has been identified previously, like a very low IOP, elevated bleb, elevated diffuse bleb, localized low type of bleb, and localized encapsulated blebs. So when not to intervene, also we have to remember that the pressure which we wanted postoperatively, if it is same and it is remarkably stable, you need not intervene. You just have to monitor these blebs. So the main purpose of the trabeculectomy is to prevent the progressive damage to the optic nerve head, and if you have achieved this, then it is well enough. If the IOP is stable, maximum post-op IOP is same as pre-op IOP with MMT, then also you should wait for intervention. Even if you want to start a single AGM, it's okay, because this can be considered as a partial success. So can we resuscitate the failing bleb? Gonioscopically need to confirm a patent sclerectomy. Evaluate bleb's function and potential. Apply pressure 180 degree away while observing through the slit lamp. So you know the AC is not flattening, and you can perform it forcefully if no bleb forms with a light massage. You can push directly adjacent to the side of the scleral flap with a blunt object or a cotton swab and see if it is forming. Apply pressure with a finger directly over the bleb through the upper eyelid also, so the whatever fluid is collected there gets displaced, and this also can resuscitate the bleb. So within early postoperative first to 2 weeks, you can use aggressive use of predacetate, administer subtetanus 5-FU, release the releasable suture, laser suturolysis with massage also can be tried. uh, first 1 to 2 months, you can again try releasing the suture, laser suturolysis, predacetate drops, subconjunctival 5-FU or triamcinolone along with digital massage. And after that, you can still attempt laser suturolysis, though the success would not be so good. But if you have used MMC, needling in OPD can be tried at slit lamp with wide illumination and low magnification. In OT also you can try, because patient would be comfortable under microscope, and or you can have a dissection with internal revision in OT. So these points would be discussed by later speakers. Routinely assessment of long term is done by clinician on a slit lamp, but it can be challenging. Outcome of these TRAP patients is different for different patients, and there is individual variation, and bleb morphology is an important factor and predictor for this. So there are many bleb grading system. They consider morphological bleb configuration. This facilitates the long-term follow-up of blebs and may predict potential signs of failure early enough to intervene. So this is a bleb. So according to Moorfield's system, we can grade this bleb. We all know about this, so I am not going to detail. So they can be classified as diffuse, microcystic, flat or encapsulated. The next system is Indiana bleb. These are the systems which are used commonly. So the parameters here used are bleb, central height, horizontal extent, vascularity, along with Seedl's leakage also. And there is third one, that is Indiana bleb appearance grading system. And Mainz bleb appearance grading system. So this also considers height, vascularity and transparency. So limitations is depends upon bleb morphology and function, but it is subjective, and findings of bleb height and diameter and presence of microcyst or vascularization lies within the clinician, and determination of morphological appearance of the bleb gives no information of its internal structures. So we'll see UBM and OCT how we can help use this. So UBM is sensitivity is very high, 91%, and specificity is good. So eye cup is used in patient's eye, but the process is time consuming, and in a patient who has recently undergone trabeculectomy may not be useful because of the possible of risk for a bleb infection. So ASOCT, we know that it is a very new tool and which can be used very clearly and comfortably for the patient. No coupling medium is used. Position and orientation of the scan can be localized and visualized, and it offers us a better alternative. So bleb patterns using ASOCT can be diffuse filtering blebs, cystic blebs, encapsulated blebs, and flattened blebs. So here you can see that the diffuse filtering blebs, you have multiple subconjunctival areas over here. You can find out various patterns, pockets of fluid collection, and low to moderate intrableb reflectivity is there. So cystic blebs, you find a cyst over there with a thick conjunctiva with a very low reflectivity of the fluid which is collected over there. Encapsulated blebs, obviously the wall is thick with a fluid and you can see a steel offering around it. Flattened blebs, obviously the fluid drainage will not be more and the conjunctiva and this reflectivity is much more higher without any intracystic fluid collections. So let's see them one by one in a real time scenario. So this is a Moorfield classification, this is Indiana classification, and this is a diffuse filtering bleb. There is a lake under scleral fluid under the scleral flap over here, and you can see the root under the scleral flap. So this bleb is a avascular bleb, or V1 you can say. The CDUS is negative, but the fluid is collecting over there and it is circulating and the pressure is good in lower teens. So this is again bleb where you can find out the scleral root. This is a avascular cystic bleb and there is a suprascleral fluid space along with root under the scleral flap which you can see here. So this is the internal ostium and you can see there is a collection of fluid along with spongy conjunctiva overneath. Another patient, a patient we had undergone trabeculectomy almost 12 years back and pressures are 13 in the right hand, left eye 15 to 17. So you can have diffuse ologen blebs. These are the diffuse ologen blebs. So ologen has been absorbed and you can see a fluid space over there. Though the blebs are flat, the pressure is good in the right eye and left eye it is now 15 to 17 with a collection of fluid over here, but still the pressure is not very high, like not above 20, but still now this left eye needs monitoring. Again another patient who I had operated almost 22 years back in 2000 and his pressures are continuously for last 20 years 6 and 8. There is no macular hypertony. Can I go for a minute? So you can see that you can see the scleral flap. There is a fluid under the scleral flap and you can see the conjunctiva, though it is a cystic, it is a double walled and you can see the spaces over there. So that's why the pressure is remaining low in this patient and he is maintaining very well with this without any visual complications. So another same patient, another of the same patient, you can see the spongy conjunctiva, how it looks over the scleral flap. Next patient, again similarly you can identify the scleral flap, you can see the fluid under, you can see the spongy overlying conjunctiva. So there are multiple, here you can find out how the trab is behaving, you can find out the fluid and root under the scleral flap in this patient also. Pressure is 12 to 14 and next is ologen bleb. This is immediately after the after 1 month after the trabeculectomy with ologen, you can still see the ologen over here with partial resorption of the ologen material, and here afterwards you can see the fluid which is collecting and in the ologen and under the ologen which is partially resorbed. So ologen blebs are also good, which we can monitor here. This is again the internal ostium and the fluid pathway is there and the conjunctiva is really behaving well. Again a few ologen blebs. So here you can see the bleb is elevated according to MBJS, the vascularity is 2, height is 3. So these are the good blebs. You can find out the internal ostium along with the fluid collection under the scleral flap and conjunctiva. So the take home message is monitoring of the bleb is crucial. Here we need to have all three parameters like serial IOP in post-op period, morphological grading and imaging with ASOCT. A failing bleb requires careful evaluation to determine the predominant cause, and timely and prompt recognition of a failing bleb is crucial to identify the underfunctioning blebs at an early stage, and this helps us to maximize the likelihood of its rescue. Thank you for patience.